Awesome. Well, good evening, and thank you for attending our session this evening. This is one of the more fun sessions that we have the opportunity of doing each year. So Jay and I get a chance to talk about all the great stuff that's happening in our state. And I think I would be remiss if I didn't start the evening with just acknowledging what a beautiful day we have had. I mean, whether you're at home this evening or you're here in the room, I mean, this has been like the perfect spring day, so a great way to bring us all together. I'm going to go ahead and just acknowledge the fact that I don't have any financial or commercial interest to disclose regarding this talk. Objectives, I'm going to actually cover objectives as I go through the presentation, and I'm going to jump right into, this is one of the slides that I try to use with presentations that I do regarding NCAP, no matter where I'm presenting. And that is to actually acknowledge that there are three key initiatives by which the Board of Directors for NCAP and myself that we are always operating under. The first thing is building awareness, whether that's awareness about the association and what we have going on and the role of pharmacists in the care of patients, or if it's getting pharmacy to the table with external stakeholders. The other area is in creating value, so making sure that whatever we are working on, whatever we're providing, can we answer that question of whether or not this is actually generating meaningful value for some of our members? And then the third one is that generating a voice. And tonight's presentation will give a lot of evidence to the importance of generating that voice for pharmacy. But it's in establishing different types of partnerships, helping set policy, and then also advocating, whether that's in the area of legislation or in regulation or policy. And all of these are important aspects of what your board of directors within NCAP are working on and how we're trying to represent pharmacy in the state. So I'm going to jump into the first objective, and that is to describe current issues related to the profession and the practice of pharmacy in North Carolina. And the way I would like to do this is by just sort of acknowledging that our issues really are on par with what we see happening nationwide. Our issues have to do with PBM unfair business practices and escalating drug prices, also dealing with transparency around drug pricing. And I think one of the things that's really sort of shined more light on this is that this has found its way into mainstream media all over the nation and also here within our own state. And now that state governments are also beginning to figure out that they are losing dollars fist over fist versus the projected savings that they thought they might be generating by contracting with PBMs, that has really begun to put more attention, more effort in opening up what we call the black box, which also is known as the transparency box. Provider status for pharmacists, payment for the provision of patient care services, whether that is on a fee-for-fee basis or payment for patient care services in conjunction and collaborating with physicians that are more on a value-based payment structure. These are all things that we are working on here in North Carolina as well as nationwide. The opioid epidemic continues to stay front and foremost. One of the things that NCAP has been doing is really trying to work really seriously on sort of elevating that role of the pharmacist in a variety of ways to work with primary care, work with behavioral health in our communities to actually be able to make a greater impact. Expanded scope is also an area that many states are working on. I will also like to say that it may surprise you to actually know that the National Governors Institute, the Patient-Centered Primary Care Collaborative, Centers for Medicaid and Medicare, and also the CDC, all within the last few years, all of those organizations have called for removing barriers and working to better facilitate having pharmacists practice to the height of their education and training. So scope, expanded scope, and pharmacists practicing to the fullest of their training and education have not only are things that we are working on here in North Carolina, but also in many, many states. And then there are a number of state-specific issues, and some of those I will get into as I go forward in the presentation. But as you might imagine, because we all have different scopes of practice and we all have different state laws, you can kind of understand why one state might be working on X issue, but we may not yet have that as an issue in our own state. So sometimes it's whatever the environment or landscape is that's occurring that's sort of driving, like, what are the key issues or key initiatives that we are working on. So objective 2 has to do with describing the current pharmacy-related legislative and regulatory issues in North Carolina for this year. And this slide is actually to put the primary legislative issues front and foremost. One of those is modernizing our collaborative practice authority. We have another bill that's actually trying to bring licensure and greater transparency around PBM. And a third one has to do with increased penalty or criminalization for breaking and entering in pharmacies. And then there's another bill that is expanding immunization authority for pharmacists. And I'll be covering each of those. So I'm going to go in reverse order, and we'll do the expanded immunization authority bill. This is House Bill 388, and I'm providing you with the information so that you at home or here in the room, if you decide that you want to learn more about any of these bills, please feel free to contact me at NCAP, but also I'm giving you the information so that you can find this by going to the North Carolina General Assembly website and be able to pull all this up. But the immunization, or the immunizing pharmacist, is a short title of the bill. It's an act to allow immunizing pharmacists to administer influenza vaccine to people 10 years of age and older, and to administer vaccines recommended by the CDC and prevention for people at least 18 years of age. And that's really not different, but what it is there's a number of vaccines that's been added to our list of what we can provide, assuming that this gets passed. So the House bill is 388. Primary sponsors were White, Dobson, Cunningham, and Sasser. And there is a companion bill in the Senate, Senate Bill 309, that the primary sponsors are Bishop, Fouché, and Krawiec. I'm not sure how to pronounce that, but I think it's Krawiec. The key things within this bill. So at the top, underlined, you will see that being able to give the influenza vaccine to individuals aged 10 years of age or older. And there's also a line in here that goes down to the age of 6 if there is a specific prescription order initiated by the prescriber following a physical examination of the patient by the prescriber. So I think there would be some limited windows of opportunity for that age 6 to 10, but at age 10 and up, that's bringing it down from, as you can see through the cross through, is age 14, which is where we've been in our state for a while. This is the section of the bill that actually, the 3 areas that are underlined, these are the new vaccines that are able to be administered by pharmacists. And they include the serogroup B meningococcal vaccines, the HPV vaccine, and the hepatitis A vaccine. So those are 3 new ones. So basically, this bill is an age change, and it's adding in 3 new vaccines to what we have in our existing statute. So the next bill I'd like to cover is the increased penalty for breaking and entering of pharmacy. This is actually Senate Bill 151 and House Bill 212. The Senate bill, the primary sponsors are Senator McInnes, Britt, and Davis. And then on the House side, the primary sponsors are Sasser, C. Smith, Murphy, and Horn. And this is a bill entitled An Act to Increase the Punishment for Breaking and Entering a Pharmacy. So this bill has gone, it's actually passed in the Senate. It is a very short bill, but it is quite a bit different from the bill that was actually filed in the Senate as to what emerged from the Senate. And so running companion bills, you introduce the same language into the House and into the Senate. And the fact that it's already moved through the Senate, it's had a few changes as it's gone through the Senate. It's in the House. It's kind of hung up a little bit in the House, and I'll tell you why in a little bit. But one of the things that happens is this bill has emerged with some changes. And so what will come out of the House may be even different from what came out of the Senate, which we'll have to work on getting those married up, so to speak, if it does in fact pass the House. So when this bill was first filed, it was to ask for any individual that breaks and enter into a pharmacy for the purpose of stealing opioids, that they would basically be found guilty of a Class D felony. That was lowered to a Class E felony. And as you can see, it was changed from opioids to controlled substances, which, I think that's a good thing in the sense that it covers all controlled substances versus just opioids. The other thing that was in the original bill was that there was a piece in there that if you assisted in the robbery, so like if you were the person driving the getaway car while someone actually did the deed of going in and taking the inventory and coming out, that there was a different class felony for that individual versus the actual individual going into the pharmacy and taking the inventory. What has emerged is actually Section C, which is additional offense. That reads, unless the conduct is covered under some other provision of law providing greater punishment, a person who receives or possesses any controlled substance stolen in violation of subsection of this section, knowing or having reasonable grounds to believe the controlled substance was stolen, is guilty of a Class F felony. So now getting to the House side, a lot of the individuals in the House, many of them we spoke with during our legislative day on March 19th, they are concerned that people who have substance use disorder are going to get caught up in this legislation. But the intent of the bill was to actually be able to have an increased criminalization for rings of people who sell drugs, of being able to basically serve more jail time. And the individuals in the House are kind of concerned about whether or not individuals who have substance use disorder are going to somehow end up going to jail versus being able to go to treatment. And so I don't know what's going to happen on the House side. I do know that there's a lot of conversation going on as to whether or not there's a way to clean it up so that this could actually indeed target the people that we're concerned about. And just to kind of give you some information, I've got some notes here regarding this more specifically. So in 2016, North Carolina was tied as number 7 in the United States for most pharmacy robberies, according to statistics from the DEA. In November of 2017, according to data that I actually asked Jay Campbell's staff to pull for me, it looked as though we began to see an increase in breaking and entering crimes around November of 2017 in our state. And then when you move forward and you look at December of 2017 and take all of 2018 into consideration, it appears that we saw about a 300% increase in pharmacy breaking and entering crimes. Most of these crimes were being perpetrated by professionals who gain access. They clean out entire inventories of controlled substances and are in and out of the premises within 5 minutes. So these are not, the bill is not meant to really target individuals that are people who have a disease, a substance use disorder, but it's meant to target the criminals that are actually stealing and diverting the stuff out onto the streets and into our schools and communities. So I'm going to move to the next one, which is the Pharmacy Benefits Manager Licensure Bill. And this is a beast of a bill, so I'll start with saying that. It is multiple pages, but the good thing about it is that this is addressing a lot of the concerns, or it's an attempt to address a lot of the concerns that many of our independent pharmacists in our state have and continue to face in running their businesses. This is House Bill 534 and Senate Bill 632. As you can see, House Bill 534 was filed in the House yesterday, and Senate Bill 632 was actually filed earlier today. The primary sponsors in the House are Sasser, Murphy, Lewis, and Bell. And on the Senate side, we have Britt, Heiss, and Tillman. And this is an act to establish standards and criteria for the regulation and licensure of pharmacy benefit managers providing claims processing services or other prescription drug or device services for health benefit plans. So I'm going to start out by just identifying some key parts of this bill. I'm not going to go through the entire bill because it's rather lengthy and very complex. but there are some key points that regardless of what sector of pharmacy that you practice in, I like to say that we are all pharmacists first and foremost, and anything that we can do as a profession that preserves or saves or makes things easier in one sector of pharmacy is to the benefit of all pharmacists. So this first section of this bill has to do with licensure. In our state, PBMs have been able to work, practice, perform their services without having to be licensed, which means there's no real way to hold them accountable or to regulate them. And so this is an attempt following a number of other states that have basically called for licensure of PBMs to operate and practice in your state, being licensed with the Department of Insurance, so that the commissioner of the Department of Insurance has more authority to hold PBMs accountable to the laws that we already have or laws that we would pass in this bill should it be successful. There are also some fees there that they would have to pay, and that money obviously would be used to help shore up the services or whatever that would be needed to run what the commissioner would need to do. This page, I wanted to emphasize that it gives the authority to the commissioner to adopt rules establishing licensing and reporting requirements for PBMs consistent with the provisions of the article, essentially. So if this were to pass, be written into law, this gives the commissioner the ability to pull together in whatever way that they need to establish the licensing and reporting requirements that would be part of enacting the law. Now, we already have consumer protections under a previous audit bill. So we had an audit bill of 2010. We then had in 2017 a revised audit bill. And there were a number of consumer protections that went into effect that was signed into law in July of 2017 by Governor Cooper. And that was the bill that actually passed the prohibiting PBMs from putting in gag clauses so that pharmacists could not, in their contracts, they were being told they could not talk to patients about, a cheaper price or whatever. So we've had that since the summer of 2017, essentially. However, when you're not regulating, you're not sort of holding groups accountable, there's lots of little nooks and crannies and ways to get around things. And so what we're trying to do in this section is to shore up or clean up some of the areas of where we've already begun to notice how PBMs can sort of get around some of our laws. So if you'll notice in section B, where it says a pharmacy benefits manager shall not, through contract, prohibit, restrict, or penalize a pharmacy or pharmacist for any of the following. Number one is in our law, but what we're doing is we're striking through and putting more specific language in there. So at the end, you'll see it used to say, as delineated in the contract between the pharmacy benefits manager and the pharmacy. So we're asking for that to be removed because we want to be able to just purely say that, if they cannot prohibit the ability to offer or provide direct or limited delivery services to an insured as an ancillary service of your pharmacy. You'll also see that in section 2, there's more information about not interfering with the pharmacist's ability to practice to the scope of which they're supposed to be able to practice in our law. There are some things that PBMs put in their contract which keeps you as a pharmacist from being able to say or do, which gets in the way, quite frankly, of being able to practice pharmacy. And so putting section 2 in. And in section 3, discussing information regarding the total cost for pharmacist services for a prescription drug or from selling a more affordable alternative to an insured if a more affordable alternative is available. Pharmacy benefits managers shall not prohibit a pharmacy or pharmacist from sharing proprietary or confidential information, disclosing information to the commissioner. So this is important. So this gives the pharmacist the ability to tell the commissioner of the Department of Insurance when things are going awry or you believe that PBM is violating information within these laws. So this is just moving on within the bill and still in the consumer protection section. At the top, pharmacy benefits managers shall not charge or attempt to collect from an insured a copayment that exceeds the lesser of the following amounts. And this is just cleaning up, putting more concrete information into language that already exists, but we're finding is being sort of skirted by some of the PBMs. And then at the bottom, an important element of this bill is that no pharmacy benefits manager shall cause or knowingly permit the use of any advertisement, promotion, or solicitation, representation, proposal, or offer that is untrue, deceptive, or misleading. And so this section is sort of the beginning of some anti-steering language that we've seen happening within our state and many states. So continuing on at the top, well, this part has to do with, again, more of that anti-steering. So they shall not require an insurer to use a pharmacy benefits manager affiliate. It's like a mail order or a specific contracted entity for filling a prescription or the provision of pharmacy care services. And the insurer shall not be restricted from utilizing any in-network pharmacy or pharmacist for a prescription drug covered by the health benefit plan. And so there are some concerns about the language of 1, 2, and 3 that's in this draft or that's in this bill. One of the things that's already been discussed is whether or not we can figure out how to strike that, because an example that was brought forward today in some of our conversations is could there be the ability to go so far as to say that insulin, which has to be kept at a certain temperature, might be considered a drug that requires special handling. And so there's a lot of concern about how things would be interpreted. And so one of the things that we're talking about is whether or not we can clean up H even further. But for now, at least some of the any willing provider language is in here. And that's the part that we were looking for. So at the bottom, a pharmacy benefits manager shall not directly or indirectly charge a reasonable fee or adjustment for the receipt and processing of a claim, or otherwise hold a pharmacy responsible for a fee or adjustment related to an adjudication of a claim if the claim meets any of the following. And so there's 3 specific issues there. That one is the fee or adjustment is not apparent at the time of claim processing. The fee or adjustment is not reported on the remittance advice. The fee or adjustment is charged after the initial claim is adjudicated at the point of sale. So this is trying to get at some of the retroactive charges or fees that a lot of independent community pharmacists see happening. In this section that I'm trying to highlight here is pharmacy benefits manager shall not require the use of mail order. So again, this is part of anti-steering, driving people to mail order. But of course, we have to put in that unless the health plan specifically is calling for the use of mail order. So we can't really keep a health plan from being able to ask for mail order, but we can, through this legislation, try to control PBMs from driving people to mail order. And then a pharmacy benefits manager shall not prohibit a pharmacist or pharmacy from charging a shipping or handling fee to an insured requesting a prescription be mailed. So if you're a pharmacist in a pharmacy and you mail something, and some of the contracts, it actually prohibits your ability to charge a fee for mailing something to your patient. And this is actually negating that. Right. In the middle on this page, a pharmacy benefits manager shall not engage in a pattern or practice of reimbursing independent pharmacies or pharmacists in the state consistently less than the amount of national drug average acquisition cost, or actually I believe it's supposed to be national average drug acquisition cost. We refer to it as NADAC. Pharmacy benefits managers shall ensure that dispensing fees are not included in the calculation of maximum allowable cost price. So dispensing fees vary all over the place, and a lot of times because they're not exactly transparent in how they calculate the maximum allowable cost, for which a lot of your appeals are going, like when you appeal something and you say you're paying me less than what it actually cost me to purchase it, and one of the denials is that, fair market price shows that this drug could be purchased at X price. We're actually stating that they cannot include dispensing fees to be part of that calculation. Or we're also asking for greater, but in this document, we're also asking for greater transparency around how they actually calculate the cost. There's a section on claims and overpayments, and there's also a section at the bottom here that has to do with pharmacy benefits manager networks. So this is, again, language placed in a specific section of the bill that has to do with any willing provider. So giving pharmacies the ability to be in the network if they want to be in the network. This last section is about some of the controls that the Commissioner of the Department of Insurance would have. It's calling for reports and information around rebates, greater transparency about where that money goes, how much money we're talking about, and it gives the authority to the Commissioner to call for an audit to be able to look at that information. And then this is the enforcement section that ties into the previous section, basically giving the Commissioner the ability to examine or audit the books. So this is, as I said, it is a beast of a bill. There's a lot of issues that have been happening with PBMs nationwide. And what we've tried to do in this bill is actually shine a light and put more changes in our existing law that we already have to shore up our audit protections, and then to build in new things like licensure required for PBMs to practice in our state, and giving our Commissioner of Insurance the ability to do audits and to gain greater transparency. So that brings me to the next bill, and this is modernizing North Carolina's Collaborative Practice Authority. This bill, before I tell you more about the bill, I want to sort of set the stage a little bit. So this slide at the top is showing that, putting all of us sort of wrapping our mind around why modernizing our collaborative practice bill is important. So we have a rapidly increasing chronic disease burden nationwide. So North Carolina is no different. We are seeing steadily rising costs for healthcare. And there are two big things. They're not the only things, but there are two big things that are fueling that. We have an aging population, and we have the opioid epidemic going on. And then when you look at what is happening with primary care, so there was a report back in, I think it was, can't remember what year that was, but there was a report that came out from the U.S. Department of Health and Human Services that had projected a nationwide physician shortage by the year 2020, with a sort of disproportionate amount of that shortage being in primary care, so a greater number would be in primary care, and more so in rural areas. So when you think about North Carolina, most of our state is considered rural. And then there was, just a few months ago, the American Medical Colleges, so the Association of American Medical Colleges, actually released a new study or report showing data that projects that shortage the shortage that was projected for 2020 will actually continue to worsen and be worse than we had expected by the year 2030. And again, sort of the key areas were rural areas and primary care. And then there was a George Washington University study that actually was published last year that projected North Carolina to have the second largest nursing shortage in the nation by the year 2025. We have right now, a little under 2 million North Carolina residents living in health professional shortage areas. And then when you think about how can we utilize all healthcare professionals to the height of their education to be able to collaborate and to provide care to patients, one thing that we have a lot of are pharmacists. And so how do we work to try to get pharmacists practicing to the height of their education and helping bring care in collaboration with physicians and nurses to these areas where we really need more care provided. So the way that we currently provide collaborative care in our state right now is through the clinical pharmacist practitioner. And we have a little over 12,500 pharmacists that work and reside in our state. So this number is excluding retirees, and it's excluding people who are licensed in North Carolina but do not live and work here. So it's a little more than 12,500, but it's definitely greater than 12,500, and I don't know the exact number. So then when you look at the number of CPPs that we have, and one thing that'll help also along this line is to know that we have had the CPP statute in place since 1998. We have less than 300 CPPs as of September of 2018 that actually are active practicing CPPs. And then when you look at where these 294 individuals are practicing, the vast majority are part of health systems or aligned with a health system. Very few are in the community, and the ones that are in the community are not actually providing services out of a community pharmacy for the most part. They are going into physician practices to be able to provide that or into a clinic to provide it. So and another part about this is when you look at where these 294 CPPs are practicing, very few of them are located east of Wake County, and very few are in rural areas in the state. So our statute, as I mentioned, dates to 1998. There's a great need for us to modernize it because it is one of the most restrictive in the nation now. In fact, some of our colleagues at NASPA have a scorecard where they take different pieces of different states' way that they conduct collaborative practice, and they have a scorecard to kind of place the states as to who has the most easily facilitated or the most active, all the way down to the states that would have no collaborative practice, which there are still two, Alabama and Delaware. Now, when you look at North Carolina, of the 48 states that have collaborative practice, and then if you add the District of Columbia in there too, we're now at 49, so we can consider DC as a state for a minute. We have 49. Of the 49, North Carolina ranks 36 as one of the most restrictive, most difficult to facilitate. And so part of that has to do with the fact that we were a pioneer in 1998. We were setting the bar. We were one of 3 states that was actually going after the ability to provide collaborative care. And so for all those people back in 1998 that were involved in leading this effort, major kudos, and I thank you for that. But we have sat still for a long time, and we've been surpassed. And now it's time for us to bring it up to speed and modernize it. So our language, and when you think about when you're going to be the first, how do you get people to agree? How do you get doctors? How do you get the medical society? How do you get folks to want to actually do this and move forward? And one of the ways that you do that is by putting in a lot of restrictions. And so that's kind of where we are. We now see a lot of states that are actually out there that do not have as restrictive. In fact, one of the things that we're asking for in the bill is actually the ability for any pharmacist, any licensed pharmacist, any licensed physician in good standing with their board to be able to collaborate should they wish to collaborate. The states in green, so there's 33 of them, are actually states that allow any pharmacist, any physician to collaborate should they wish to. So that's just an example. We have a bill. It came out of bill drafting late yesterday. We're working to get it introduced in the House as soon as possible. So we don't have a bill number yet, but as soon as when we have one, NCAP will be providing information on that. But we have a bill to be entitled An Act to Improve Access to Patient Care Services via Collaboration Between Physicians and Pharmacists. The whole purpose for this is to modernize and enhance our existing collaborative practice statute to better facilitate the implementation of collaborative practice in all patient care settings across our state. The key elements of the bill are to open up collaborative practice to any physician, any pharmacist in good standing with their board, to make the language within the existing statute regarding agreements less restrictive, to reduce regulatory oversight regarding the establishment of contracts. So it's basically giving more power to the physician and the pharmacist entering into these agreements, primarily giving more power to the physician to establish what they wish to have that pharmacist be able to provide as care. And then allow the physician to determine the number of pharmacists he or she deems appropriate to collaborate with or to supervise. And a couple of other things has to do with, one has to do with the structure of how things are approved today, requires a committee approval of not only the pharmacist to be able to collaborate, but approval of the actual agreement between the doctor and the pharmacist. And so we're actually calling for that to be done as a registry, sort of similar like our certified immunizer registry. And also there would be a smaller annual fee structure that would be in place. And that fee would be for the CPP when they pay to renew their license at the end of the year. We kind of envision this being an additional fee that they would pay as a CPP. And then there are many states, I believe the number is 27 states that allow physician assistants and nurse practitioners to collaborate with pharmacists. And so we've built in some language that would allow PAs and NPs that are on a team with a physician to be able to also enter into that collaborative agreement if the physician would like for them to. So I sometimes get asked, well, what about provider status versus collaborative practice? So we already have collaborative practice. Why are we working on modernizing that versus why aren't we going after provider status? So one of the things that in all of our research that we've been doing, I actually stumbled across an old statute on our records which was built around malpractice. And in that statute, it actually states that pharmacists are healthcare providers. It's talking about it in the context of malpractice. So given that provider status has not been passed on the federal level, a lot of our colleagues, the APHA, ASHP, et cetera, have now been calling on the states to try to do more, to try to get provider status at the state level. But as we look to modernize our collaborative practice statute, what we're doing is we're building in a line into our bill that actually calls this older statute. We actually list it in the bill, and we're sort of saying that, in other words, we're calling out, and we're saying, well, if we're considered providers for malpractice purposes, then we are providers. So we're not asking for permission to be called providers or to be recognized as providers. We're stating that we already are providers in the bill. And so it'll be interesting to see how that works. I'll just put it at that, all right? And then how does modernizing collaborative practice statute help with payment for services? So most states that are running provider practice status bills right now, they are doing it to gain provider status for the purpose of being able to be paid for services by their Medicaid program. Here in North Carolina, we have CPP already as the recognized designation for payment for patient care services provided by pharmacists. So modernizing our collaborative practice authority to make it easier to better facilitate more pharmacists becoming CPPs allows for pharmacists to do more collaborating and to be able to utilize that CPP status to be able to bill. So in addition, these states that have been successful or they're currently running bills for being recognized for payment by their state's Medicaid, they are the same states that are in the 33 that allow any licensed pharmacist, any licensed physician to collaborate. So our approach, just to kind of sort of share our strategy of what we're thinking is that if we can open up our collaborative practice authority to make it so that any licensed pharmacist, any licensed physician can collaborate, we already have Medicaid ability. What we will then do is sort of catch up very quickly to what Washington State has been doing, where they have been working with private payers. Because if we have numbers, so leverage of having as many people out there have the ability and are willing to collaborate, then we begin to have a little bit more power to actually have the conversations that are needed with the private payers in our state. Regulatory issues. So there are two that NCAP is currently working on. One is telepharmacy, and we have John Kessler and Lindsay Amarine, who are our co-chairs for telepharmacy, for our telepharmacy task force. That group has been working diligently since about January 2nd. The plan is that they will be bringing forward a proposal for how, so right now I should say they're looking at the landscape of telepharmacy, like needs in our state, how this compares to other states, lessons learned from other states in the telepharmacy area. And the one sort of thing that I asked John and Lindsay to not lose sight of is the cognitive services that a pharmacist provides. So we tend to think of telepharmacy as all related to the provision of product. So like a satellite where it's virtually being monitored by a pharmacist, but it's being manned by a technician. So that's kind of what we're talking about. But we don't want to do that. I don't want to do that. I'll say that. I'm not sure my board would want to do that unless we have the ability for pharmacists to be able to provide the cognitive skill, the patient education piece that would need to be provided in that. So John and I've talked, Lindsay and I've talked, their group is working diligently. The plan is that we would have some form of proposal for the board of directors for maybe by May or June. And then my board, so the board of directors for NCAP, we would then make a decision on what or how to move forward. And then hopefully it's at a position of where we can then take something to our board of pharmacy after that. So that's where we are with that. Assisted living facility emergency kits. So for those of you who work in long-term care, there's the ability to have an emergency drug supply in skilled nursing facilities. The level of illness and care that's needed in assisted living today is a lot like skilled care used to be decades ago. And so there's some need that's been identified by some of our colleagues in the long-term care arena that would like to see emergency drug supplies, or what we call e-kits, provided in assisted living facilities. So that requires a rules change. And in order to go through that rules change, we have to collaborate with our assisted living partners, so the Assisted Living Facility Association. And we already have a draft proposal, but we're now at that point of where we're going to need to bring in other stakeholders to be able to start that process of looking at a rules change. Prep for future legislative issue. So we have another task force that's been working since last fall, and it is a medical cannabis task force. We've seen medical cannabis approved in many, many states. It's over 30 now. We know it's coming. The question is, when it comes, we want to be a proactive part of that. We want it to be a pro-pharmacy. So just like the telepharmacy work that's going on right now with our task force, looking at it through the lens of pro-pharmacy, we're looking at trying to figure out how do we do a medical cannabis bill in the future that is pro-pharmacy for our state. So hopefully I'm not making Jay cringe at the back table on this issue, but
oh, you are.
Yeah. So we have you may be surprised to know that there has been a bill introduced in the General Assembly. Every long session, for many long sessions, someone told me, dating back as early as sometime in the mid-2000s, I don't know the exact year, but The person that has been behind that is a very liberal individual, sort of a grow it in your own yard kind of person. And that's not going to get traction in our state, nor do we want it to get traction. We want this to be done in a way that's similar to like a state like Connecticut or New York or Pennsylvania has been able to do theirs. So again, this task force is looking at the landscape. They're looking at what has worked, what hasn't worked, what are the problems, and they're looking at the data around patient care as well. So looking at some of the science and then trying to figure out, okay, what do we want to do in North Carolina? Do we want pharmacy at the table? Do we not want to be at the table? And so that's going to be a debate for the board of directors once this group finally gets to that position. We're not looking at anytime soon. The earliest would probably be a 2021 window. But again, I don't have a crystal ball, so I don't really know exactly. This is a save the date that's important. This is you just heard me go over all of our pharmacy legislative issues. This is a save the date for a virtual legislative day. We had an actual in Raleigh legislative day on March 19. This is going to be one of hopefully 2 virtual days, the first one being April 25th, and we'll probably be targeting another one sometime in May. So save that date so that you can participate. This is our website, so ncpharmacist.org. You see the red circle, legislative updates. Right now, because the PBM stuff has just dropped, we're in the process of trying to put talking points and all this stuff together so that we can actually do an update to our updates and have information for the PBM bill. Right now, there's lots of information on there for the collaborative practice information because we have been working on that for over 2 years at this point. And then we'll also be putting some more information about the immunization bill, the breaking and entering bill. As I learn more about that, we'll be putting more information out in our e-news on all of our legislation. But this is a good place to go to try to get more information. And of course, the General Assembly is a great place to go to get the latest updates on how a bill is moving through. So my final objective is describe recent changes at NCAP, including upcoming activities and educational opportunities. And this is all about that create value, invest sort of, that meaningful value. So everything that we're working on, it should be, we should be able to answer the question, is this going to help us create value for our members? So one of those is region engagement. And region engagement is important for us because there are a lot of pharmacists out there across the state practicing in the trenches, and we've got to figure out how to better connect with them. So we've begun some initial conversations with local associations to see if there's a way that we can somehow structure regions for the purpose of taking information out into the regions and receiving information back from regions. Another one is the new ambulatory care practice forum. This has been called for. We are in the process of sort of going through, okay, what do we need to do to actually create an ambulatory care practice forum? Our plan is that this would be something that we would complete this year. There's also a desire for a new independent owner/managers network within the association, and so we have begun to work on this as well. Expanded virtual communities. We have a technology now called Higher Logic, which allows us to create virtual communities where people can interact with that have similar practice settings or like-mindedness about issues. So for an example of that is everyone that's gone through our advanced opioid training program, they are in a virtual community communicating with each other and sharing ideas and whatnot. So that's just an example. So we're planning to do more expansion of our virtual communities this year. New certificate level trainings. We have one that's supposed to come out this summer, which is a continuation of our work in the opioid space. We're hoping to launch the medication-assisted treatment certificate level training sometime this summer. And to begin, we're hoping that that will be actually mostly an online type of training, where we would have some evenings of where the the cohort of individuals taking the training would actually come together to have dialogue and discussion. So, but we'll see. We're still working with the team that's actually doing the development of that. And the team is made up of pharmacists and physicians that are already working in medication-assisted treatment in that space. Strategic planning. This year is the year where NCAP needs to do some additional strategic planning. Our next board meeting, which is coming up in another week, we are going to be talking about our steps for how we want to move forward with doing our strategic planning this year. And then Medicaid MCOs. So be remiss, we are transitioning to managed care for Medicaid in our state. And what we want to try to do is pull together an MCO pharmacist conference where we can bring together the MCOs, pharmacists that are in the trenches, and be able to have open dialogue and discussion about what this is going to look like, what are the concerns that pharmacists have. They're very interested in so far the dialogue that we've had is, and I say this with a little bit of tongue-in-cheek, but I must admit, they are very interested in actually holding this meeting, and they're very interested in opening up dialogue with pharmacists in our state. And then pharmacy work environment, job market, salary analysis. This is going to be a multi-state initiative. It was discussed a couple of weeks ago out in Seattle at the NASPA meeting on the front end of APHA. And I would say of the 37 state association executives that were there at that meeting, it seemed like everybody in the room was interested in doing this together so that we could share the burden, share the cost, and basically, reap the benefit of doing this type of analysis for our state. Again, another save the date, 2019. This is our annual convention. We'll be at the Benton Convention Center in Winston-Salem. It's a Thursday, Friday, so September 26th, 27th. A big portion of the meeting will be devoted to transitions of care. So we're trying to sort of share best practices so we can learn from each other. And it's intended to sort of bridge all practice arenas. So again, that planning committee, the convention planning committee, is already off and running. In fact, I was answering an email a minute ago from the co-chairs for that. So I'm gonna, this is my last slide except for the usual, contact slide. And I have some specific information. There it is. So I'd like to start by just saying there's strength in numbers. The individuals years ago that had the foresight to merge all of our separate associations, to bring us together so that we could have a collective voice, so that we could have power as a profession in the state. This slide is basically trying to get to the importance of that, a collective voice, power behind our numbers when we come together. And we've got major legislative issues that we're trying to move forward. If we don't come together to move those initiatives forward, we're going to just keep spinning our wheels and not getting the type of response that we really need for our profession. So I oftentimes get asked from time to time, it's not real frequent, but it's more than you might think. I'll get asked about why North Carolina is no longer really at the national level. We still have people from North Carolina that are giving great talks at national meetings, but North Carolina is no longer looked to as a state that's driving policy and legislation regularly, like being the lead. In fact, on all this PBM stuff, we've looked to a number of other states to see what they have done to try to help us in crafting what we need to do. So how do we begin to become a lead again in leading the profession, not just for our state, but in setting an example for the profession nationwide? And so when we, today people look to Ohio and Arkansas and Washington and Arizona and even Tennessee. And I just want to emphasize that for us to be able to lead like that, we have to get more people engaged with the association. All these states I mentioned have very strong pharmacy associations. And I have always told people when I speak that I try to be as transparent as possible, that I don't sugarcoat it, and I try to share whatever I can. So I wanted to do some numbers this time, just to give you a flavor of what it takes to have a strong pharmacy association. It takes 425 dues-paying members to cover the cost of a full-time lobbyist. It takes 284 members to cover the cost of rent and utilities. It takes 263 members to cover the cost of a full-time staff member. It takes 79 members to cover our accounting services. It takes 80 members to cover the annual cost of our association membership service. So it's our AMS. It's our database that we use, that we communicate and do everything, our website, et cetera. But it's more than just a website. And some other technologies are thrown in there. The 121 popped up also, and that's what it takes to cover a part-time staff position to do whatever. It could be communications, it could be event planning, whatever. And it takes another 515 members to cover the cost of a full-time association executive. At the top in blue, so we have made some strides. We have gained some members. When I started, I started crunching the numbers a little differently. I looked at how many pharmacists work and reside in our state. Now, our retiree members are super important to us, but we recognize that they're retired. And so we need to depend on new pharmacists coming into the association. So when I started, we were at 8.7%. June 1 will mark 3 years of me being on the job as the executive director, and we are just now at 12%. If we could get to 20%, we would have an additional almost 200 grand in our coffers to be able to do more work. If we could get to 1 in 4 pharmacists, we would have an additional 314, almost 315,000 to work with. If we could get to 1 in 3, we would have $500,000 more that we could do. Just think what we could do with that money. And I share this information because I know that all of you sitting at home or here in the room, you're not in the office. You don't see what it takes to the expenses that are involved. You don't know what all it takes to run the association. I've got nothing to hide, but I do have an ask, and is that I need your help, and that's what this slide is. I need you, if you're not a member, to join NCAP. You see everything that we have going on. We need your help. And if you've got friends that you work with and they're not a member, to help encourage them to also join. And I will close at that.